始。咁自上次會議之後發出嘅文件就有只係有一份嘅，係有2位公眾人士就呢個巴士嗰個空氣質素提咗啲意見嘅，咁傳閱咗俾各位委員㗎啦。咁就若果冇其他意見嘅話，就議程第2項，下次會議討論事項個待議事項一覽表同埋跟進行動一覽表都已經送咗俾各位，咁請政府嘅代表入嚟啊，唔該。下次嘅例會就係6月17號，禮拜一下午4點半喺會議室3。
Date of next meeting, the 17th of June at 4:30. The administration would like to discuss waiting time management for specialist outpatient clinics in the HA and also pilot projects on outreach primary dental care services for elderly in residential care homes and daycare centers. This is a follow-up item. We'd like to know the progress of the pilot scheme. Regarding waiting time for specialist outpatient clinic, on the 21st of January 2013, we had a discussion with the secretary when we discussed the work plan for this year. And then we talked about the referral of cases of poor children and disabled children to SOP clinic. Dr. Fernando Chia, of course I agree that we should have this item for our next meeting, but can the administration give us a paper to list out clearly the waiting time of individual specialist outpatient clinics? Currently, the situation is not transparent. Although it is said that the information will be gradually available on HA's website, but I just checked a few days ago and information was very scanty. There are 7 clusters. Please give us the respective waiting times of these special outpatient clinics in all 7 clusters, the waiting time, and also the earliest next appointment, so on and so forth, and also the number of patients on the waiting lists. Can you write out a list of questions so that the administration can answer the concerns one by one? Now we are discussing the agenda for the next meeting, and the first item for the next meeting is waiting time management for specialist OPCs in the hospital authority. So Dr. Zhong would like to know the waiting time for all 7 clusters, 8 specialties. All right, patients on the waiting list, the waiting time, and I don't know whether they have any streaming system. Please tell us the priorities, the first priority, second priority, and also the waiting time for general patients, and also the number of patients on the waiting list. And any problem, Secretary? No? Mr. Chen. Usually we were given an average waiting time. While we can note the general trend, we won't be able to tell how serious the problem is looking at the average time. So please give us the longest waiting time, the shortest, for our reference. Is it okay? I think that can be found in the budget speech. Well, but many of the figures were just average figures. They have that at 10 percentile, 5 percentile, statistics for each percentile. So it's okay for the administration to give us another paper on that. So 2 items lined up for the next meeting so far. And if members have further views, please let the Secretariat know afterwards. Item 3, Regulation of Healthcare Intermediary Service. The administration has provided the paper for us, and the Secretariat has also given us a fact sheet. Is an item proposed by Dr. Kwokaki, and it is suggested that deputations be invited. So please invite the deputations to come in now.
Circulated. 啲團隊代表入緊嚟㗎啦，係咪啊？
The deputations are coming in.
OK， 首先咁啊，歡迎各位團體嘅。
First of all, welcome you all to the meeting of the panel. Channel 0 is floor, Channel 1 Cantonese, Channel 2 English interpretation. May I remind you that your submissions and our remarks here are not protected by the Electoral Powers and Privileges Ordinance. So you have to be liable for your own submissions and remarks. Each deputation will have 3 minutes to speech. Please be succinct. We've already received some submissions from you. And if we have time, members may put questions to the deputations. So we'll start with 3 minutes per deputation. Okay. The first speaker, Dr. Yang Chiu-Fan, President of Hong Kong Doctors Union. Thank you, Chairman, and members of the panel. Good afternoon. In 2006 and 2007, we attended meetings of the previous LegCo, so this is already the 3rd time we've come here on this issue. So we've always noted the problem of healthcare intermediaries, and we have raised various irregularities of healthcare intermediaries to the administration and the council, affecting the welfare of the community. So we do agree that they should be regulated, because they have agreements with insurers, and to cover consultation for patients, and intermediaries gain in between, and they have imposed restrictions on doctors regarding treatment for patients, examination, and modality of treatment as well. These are side effects of healthcare intermediary services. We have pointed this out to the administration for more than a decade. However, the government has turned a blind eye to this problem. So we hope that there should be at least one medical doctor in charge of medical healthcare service to be responsible for the medical aspect. And it's just like dental practices. At least half of the shareholders must be dentists, so that the administration can regulate the operation of such services. After all, patients' welfare is involved. And we believe a medical license should be issued by the relevant authorities. The medical council, for instance, can then set out, can ensure whether the contract or agreement will jeopardize patients' interest before these intermediaries are allowed to operate. With the union had a meeting with the medical practitioners last year to survey the amount of consultation fees being paid to doctors. On average, it was $100 per consultation, more or less equivalent to the charge of A&E department. And this has been in place for more than 10 years. It's always been $100.
香港病人組織聯盟嘅外務副主席林志釉先生，係嘛 ？OK， 林生唔該。
好，多謝主席。香港病人組織聯盟咧係認為咧喺社會上邊咧需要醫療服務嘅人士咧分為3類嘅。第一類咧係有錢人啦，咁佢哋一般咧就唔需要公營醫療服務。咁第二類咧就係低收入人士啦，咁佢亦都唔會揾私家醫院。咁至於第三類咧就係中產人士啦，咁佢哋可以喺公營啦或者私營嘅。
Have a choice between going to the public or private sector. But we all know that the waiting time at public hospitals, be it the operation theatre and so on, will take a long time. So they have difficulties in respect of choice, and very often they have to come up with a choice. The medical, as a result, the healthcare intermediaries, came into existence. But we wonder whether there is sufficient regulation regarding quality. That these intermediaries may not be supervised by medical professionals, and those who sell the products are not required to be professionally qualified before they will promote the products. And in order to make a profit, they may engage in improper sales tactics. The ordinary person may not have sufficient knowledge of medical products. Very often they think that after they pay the fee, that the disease will be cured. But as to what the treatment will cover and which will not, they do not have sufficient knowledge. Regarding the financial information, very often the doctors and hospitals will take up insurance coverage. When an incident happens, they will pay compensations. But for the medical intermediaries, they do not have minimum capital requirement, and when they collapse, consumers will stand to lose. Our alliance has the following recommendations. In terms of quality, we will suggest that the management of these intermediaries should at least have one director who is a registered medical practitioner. And secondly, there would also need to be a patient representative organization sitting on his board to monitor the performance of the organization. Regarding product information, we believe that we need to enact legislation to set up a regulator to regulate the operation and products of these intermediaries. Regarding the services referred by these medical intermediaries, they will need to be registered with the regulatory authority. Most importantly, after consumers have bought these products, they should have the opt-out option, so that they'll be able to have a refund when they choose to opt out. And also, these intermediaries should have sound financial background. Our alliance requests that they should at least have a paid-up capital of $5 million, and every 3 months they would need to submit a financial statement to the regulator. For all the information, all the money paid by clients, they would need to be deposited into an independent client's account, and after the service is provided, then the amount will be transferred to the intermediary. Next, we have the Hong Kong Federation of Insurers, Miss Senda Chen. Thank you, Chairman. We have written our submission in English, so I'll read it out in English.
Legislative Council's panel on health services to offer insurance industry's opinions on regulation of healthcare intermediary service. The Hong Kong Federation of Insurers would like to submit comments as below. In Hong Kong, healthcare intermediary service provides a third-party administration services for benefits providers, including insurance companies and corporates, who are self-insuring medical benefits for their employees and dependents. On the other hand, healthcare intermediary service may refer potential patients to clinics and hospitals in a collective manner, which provides a business portfolio for doctors and hospitals. The Hong Kong Federation of Insurers is pleased to see more healthcare intermediary service participating in the market, which encourages healthy competition, and in return, quality service at reasonable costs will be enjoyed by the parties concerned. However, as there may be substantial cash flow and credit commitments incurred in the operation of healthcare intermediary service, and the quality of medical services may be compromised for the maximization of profits, there is a need to ensure healthcare intermediary service is operating by medical ethics and with prudent financial management. As such, the Hong Kong Federation of Insurers opines that regulation of healthcare intermediary service should cover two areas. The first area is to have at least one qualified medical director and or medical practitioner present at the healthcare intermediary service management team. And the second area is to apply solvency requirements to healthcare intermediary service for its provision of credit services. Yep.
Okay. 唔該晒。下一位發言嘅香港醫學會會長係謝雄。
Next, we have Dr. Che Hong Hing from the Hong Kong Medical Association. Thank you. The Hong Kong Medical Association has already sent in a written submission. I'd just like to reiterate a few points. Just now, we've all heard the other deputations pointing out that the nature of these healthcare intermediaries are very similar to those of insurance companies. If not 100% the same, they are at least a part of the executive arm of the insurance companies. But these companies are not subject to any regulation at the moment, and this is a major loophole. It is obvious that if these companies, after they provided some medical services to the public, but their capital are not subject to any scrutiny, and should they encounter any financial difficulties, the clients will not get any compensation. And since they are a restricted service provider, the clients therefore will not have a complete free choice as to have a free choice regarding the doctors they would like to consult. Regarding the administration fees charged, there is a lack of transparency. When members of the public, patronize these companies, they don't know what standard of service they are enjoying. In the government administration's brief for LegCo CB 21135, I think a few of the points raised in this paper are misleading. In paragraph 5, they point out that according to medical practitioners registration, it will not be affected by the payment arrangement between, although the professional standards are the same. However, the patients in their choice of medicine and examination, they may be affected by the fees charged. And the service provided may not be the same as those given to other patients, and the patients may not know this. And in paragraph 7, the paper points out, also made a misleading claim. That is, for these medical intermediaries, they're restricting the choice of the public. It's not like other members of the public or those who have only taken medical insurance who would have a choice as to what sort of service they would be entitled to. Of course, the professional standard and judgment of the doctors are the same. And in paragraph 9, regarding the review of the regulatory regime for private healthcare service facilities. I'm sitting on 4 of these subcommittees. Obviously, they do not regulate the medical intermediaries, so the information in this paper is misleading the Council. Many years ago, we've asked the government to regulate these intermediaries. Perhaps it's because nobody had there had never been a fatal accident that the government is unwilling to opt for regulation. Next, we have Dr. Aaron Lee, Practicing Estate Doctors Association. Again, I would like to address the Council in English.
Has the following views on healthcare intermediary service providers. We believe a healthcare intermediary service provider should be regulated and controlled by legislation. He or she should inform the medical profession whether, 1, he or she has become subject to an adverse finding, whether past or pending, by a regulatory, trade, professional, public, industry or consumer body, or by any tax or government authority. 2, he or she has been the subject of any bankruptcy or insolvency proceedings. 3, he or she has refused, suspended, withdrawn, or made subject to a non-standard condition or restriction any license, permission, or authorization to do business. 4, he or she has been a defendant in any civil proceedings or any criminal proceedings. 5, he or she has ceased trading in circumstances in which one or more of his or her creditors did not receive full payment. 6, he or she has been disqualified from acting as a director of a company or from acting on the management or conduct affairs of any company, partnership, or an incorporated association. 7, he or she has been charged with any offense involving violence, fraud, or other dishonesty. And finally, he or she had an application to represent an insurance office refused or a previous agency cancelled. That's all I have to say. Thank you.
唔該晒。咁跟住我請個局長睇下就介紹政府嘅文件同埋。
Next, I'll ask the administration to walk us through the paper and respond to the deputations. Thank you very much. First of all, I'd like to thank the various deputations for taking the time to come here to express your views regarding the regulation of healthcare intermediary services. I think many of your suggestions really deserve to be considered, and we can explore them further in a while. For these healthcare intermediaries and their relationship with the network panel of doctors, we're talking about commercial arrangement here, and any dispute between the two should be resolved through the provisions of the contract. Regarding the rights of patients, the panel doctors have the same professional obligation to the patients, and the quality of service received by the patient should not be affected whether or not they participate in a healthcare intermediary scheme. The Medical Council has also a code for registered medical practitioners in Hong Kong, and the code already has defined standards for the provision of service to patients, including the fact that doctors has the obligation to ensure that the service provided up to professional standard, and that they should safeguard the maximum interest of the patients. And they should quality of service should not be compromised because of difference in fees, and any non-compliance will be subject to sanction by the Medical Council. For patients who participate in the intermediary scheme, if they are hospitalized, their rights and the safety should also be governed by the hospitals, clinics, and the maternity homes regulations and the relevant codes of practice. We've also made reference of the overseas experience, for example, the UK and Singapore, Canada, and Ontario, that is, and also New South Wales in Australia. In these jurisdictions, again, they do not have any regulatory regimes for healthcare intermediary services. The system regulation in these jurisdictions are very similar to that in Hong Kong. Basically, they would focus on regulating the professional conduct of doctors and the standard of healthcare premises rather than the business model of the medical services per se. Chairman, we are very concerned about service quality and the need to safeguard patient safety, and therefore we are willing to review the regulatory regime for private healthcare facilities. We will listen carefully to the views from all the stakeholders so that we will be able to enhance the standard of service by such private organizations. I think members will might probably know that we have set up a steering committee to review the regulation of private health care facilities, and this committee will look at the operation of different organizations providing healthcare services to ensure that the safety of patients are safeguarded. Today, we've heard the views of the deputations. We certainly will refer them to the steering committee and its subcommittees.
I can first try to respond to comments made by the deputations, and later on I can also answer further questions from members. The Code of Professional Conduct under the Medical Council of Hong Kong has set out the standard of service to be provided by medical doctors. Doctors have to ensure that the professional standard will not be compromised due to the level of fees it is charging. And according to Dr. Lee, some of the paper, some parts of the paper might be misleading, but I'd like to say that these are principles. Perhaps in reality there may be some departures from these principles. Still, they are principles. And many members of the profession have talked about how consumers feel when it comes to the choice of doctors and services they receive. I believe there is the need to enhance consumer education to let them understand that intermediaries are just middle persons, and doctors have to ensure that they provide services of quality under their code. And should there be any problem, patients should chase their insurers, because after all, they have taken out insurance, and insurers have their own regulatory body. And when it comes to hospitalization, there is also protection from relevant legislation. Perhaps I pause here, and I am happy to take further questions from members. Thank you. I think we have enough time to allow 4 minutes each. Dr. Kokaki. Thank you. I proposed this item because, as you all know, there was a case where a healthcare intermediary was not able to pay the doctors as promised or as agreed. So some patients could not have access to medical services by panel doctors. In 2006, that is 7 years ago, in this panel, there was already the discussion of a regulation of healthcare intermediary service. I was also a member back then. It's been 7 years. Every year, we have similar incidents. For instance, healthcare intermediaries do not honor their undertaking or their obligation, or the service standards are being criticized. And according to the administration, it has no intention to regulate such intermediaries. Now, we are talking about human lives. So if the administration is not going to regulate medical services, what will it regulate? What about less important industry in Hong Kong, such as the tourism industry, insurance industry, and even real estate agents? Now, they do not involve human lives, yet there is a proper licensing scheme with merits and demerit points, and licenses can be suspended or licenses revoked. 11.6% of the population, 11.8% of the total population are participating in such services. You understand that insurance companies will try to suppress the fees payable to doctors. And we have got information from a relevant union. The cost in government OPD is about $220 to $240 per case, whereas in some of these intermediaries, they only pay $95 to a doctor per case. That is only half, less than half of the cost of OPD, government OPD. So who will suffer? Patients, of course. But for new graduates and new doctors, they do not have any bargaining power. They have no choice but to accept such conditions of service. And if they are not willing to take up these positions, there won't be enough panel doctors to see members under these schemes. So I'd like to ask the administration, why is it so adamant? Why has it not considered a licensing system? Because such a system will not affect the services in any way. So do you have to wait until a person died because of such services that the government will finally act? Dr. Chen, so it's not that we don't want to do anything. I'd like to stress that we have a steering committee reviewing private medical healthcare services and hospital services. We are going to include this issue in the scope of review. Dr. Zhang said that we have not covered that in the steering committee. No, that is not the case. There are 4 working groups under the steering committee, namely differentiation between medical procedures and beauty services, defining high-risk medical procedures or practices performed in an ambulatory setting, 3, regulation of premises processing health products for advanced therapies, D, regulation of private hospitals. Perhaps the working group responsible for regulation of private hospitals or other working groups can cover this if necessary. There are different products being offered by healthcare intermediaries. It takes time for us to review their mode of operation and their different arrangements. So please give us time. The PS is here. We can refer this issue to the relevant working group. In fact, the PS chairs some of the working groups. So we will see whether it is necessary and how, if it is necessary, to regulate this profession or this industry. Chairman, 7 years. How much longer do you need? Since we have ample time, can you wait until the second round? All right. Dr. Zhang. Healthcare intermediaries are just like insurers. Well, there were incidents in the past involving one of these companies. There was default of payment to doctors, and some patients saw discontinuation of care by these doctors. So I can understand why the government is not willing to regulate these intermediaries. According to the paper, in 2009-2010, about 11.8% of the total population have participated or were entitled to such plans provided by probably their employers. The administration will encourage the public to take out insurance, medical insurance for themselves, probably through these intermediaries. The government has also set aside $50 billion as seed money for healthcare protection scheme. Perhaps you will use public money to encourage members of the public to patronize these intermediaries. But as pointed out by the Medical Association, these intermediaries have little transparency in its operation. The amount of information to subscribers is also low. Will doctors or healthcare professionals compromise their quality of care or the level of service in light of the payment they received? So why don't we regulate them? In other countries, there have been many incidents. In the States, there are many problems. I can't remember the name of a movie. There was a film where a father had to break the law because his son was suffering from heart disease. His son needed some special treatment. However, the healthcare intermediary denied his son of that service, so the daddy had to take hostage of this doctor so that he would provide the appropriate treatment to his son. So do we want this to happen in Hong Kong? So please think twice. The steering committee you're referring to, it's not really directly related to healthcare intermediaries. Under the 4 areas, they are not really relevant. So administration, please reconsider the issue. Thank you, Dr. Zhang, for your question and your views. As far as the steering committee is concerned, as I said, there is a working group on regulation of private hospitals. I believe the working group can cover not just private hospitals, but private healthcare services as well. And as I said, this issue will be taken up by the other working groups as appropriate. Regarding a healthcare protection scheme, of course, we will brief the panel on that issue later. Regarding healthcare insurance, we are not going to encourage or discourage the doctors to work for insurers, because healthcare intermediaries are, after all, business entities. So perhaps Mr. Yun can supplement. Thank you. These intermediaries. Now, talking about liability, if you take out insurance, well, you take it out from an insurer, and the employer has purchased services from the insurance company, so the responsibility rests with the insurer. So if a patient is denied of service by a doctor, then he will just have to take issue with the insurer. Now, if the service is provided by the employer, then the patient will just have to ask the employer. So the insurer is regulated by the Office of the Insurance Industry. So regarding the quality of service and also the safety of service, well, it is the doctor's responsibility. The doctor has to ensure that the level of service is not lower to match the diminishing remuneration. As the secretary said, there is a clear agreement between the doctor and the insurer. The doctor has to ensure that he will not go against the code or do anything that would harm the patients. So the medical council will regulate the doctors concerned. As for myself, I am responsible for the steering committee about regulation of private hospitals. Rely on hospitals, rely on the hospitals, nursing homes, and maternity homes ordinance. As we all know, we no longer has maternity homes in Hong Kong. So we'll first put in place a regulatory framework for private hospitals, and then we'll proceed to other service providers, such as group practices, made up of doctors, and we'll also consider whether individual doctors have to be regulated as well. And if healthcare intermediaries are involved, do they have to be regulated? If yes, under what principles? The insurance company is regulated by the Office of the Insurance Authority financially, and for professional standard, doctors are regulated by the Medical Council. So if there is a problem, then who should be held responsible? So the government's responsibility is to regulate the service provider first, the provision of facilities and also equipment as well. So after we have completed regulation of private hospitals, we will extend to healthcare intermediaries. Do we have to regulate them? If yes, what is the government's responsibility? How can we ensure that there is no duplication of duties with the insurance authority as well as the medical council?
Thank you. The Permanent Secretary put it very well just now. The insurance companies are regulated by the Commissioner of Insurance, doctors are regulated by the Medical Council, whereas the medical service intermediaries come under the purview of the Working Group on the Regulation of Private Hospitals. I think we have misunderstood that you're not saying that private hospitals include healthcare intermediaries. You need to, say this clearly. We have to look at the role of the intermediary in the whole regulatory process and decide whether or not they need to be regulated, and if so, how. So you have regulation at both ends, but for the intermediaries, you're not considering whether or not they should be regulated. So my question is this: the working group now, or the working group on the regulation of private hospitals, according to the data available to you, is that the same as what we are now discussing now? Will you have a more detailed study of the issue. Secondly, I have a question for those from the insurance industry. Well, you don't offer medical services, you provide the service through the intermediaries. So how do you regulate them? I also like to ask the doctors' associations. Doctors are regulated by the Medical Council. So, well, the doctors are caught in the middle. So could all the different parties give us, respond, please? I think Mr. Yuan, the Permanent Secretary, can answer the first question. Chairman, the information is basically the same as the one that we have provided. That is, for the regulation of private medical organizations, other than private hospitals. The old regulation would include regulation of private hospitals, maternity homes and nursing homes. We no longer have maternity homes now. In the past, we didn't have group practice, but nowadays you can have several doctors working together in the same premises, using the same equipment and the same operation theater. And when something goes wrong during the operation, it's a question of professional ethics. But if the premises are not properly regulated, should I hold one or all the doctors responsible? I think group practice, at least, is a partnership. But these doctors we're looking at are being employed. Are you able to regulate the person who employ these doctors? Well, these intermediaries may not be doctors. They would only organize the doctors together to bargain with the insurance company. For a single doctor negotiating with the insurance company, the letter will not talk to him. So they will mobilize the doctors and bargain with the insurance company. Let's say they have 50 doctors on hand, then they can directly negotiate the price with the insurance company. So we're talking about a commercial operation here. We need to take a look at it clearly and decide whether or not we need to step in. If we regulate, should we also regulate fees charged? If we set a minimum fee, then how much should be the maximum fee? It's a very complex issue. So far into our study, when we look at other jurisdictions like Singapore, Canada, the UK, and Wales, they operate like Hong Kong. That is, a regulated professional standard of doctors. And in Hong Kong, that's the job of the Medical Council. Next, they regulate the medical premises. As for the medical healthcare intermediaries, we've heard a lot of concern. We are prepared to take a look. That is, given our unique circumstances, we have to consider what we should do. We have to first decide what we should regulate and how. If we're going to regulate the intermediaries, if a patient thinks that the service they get is not satisfactory, should we hold the doctor responsible, the insurance company, or the intermediary? All these would need to be ironed out clearly. So at the moment, doctors are regulated by the Medical Council. So anything goes wrong in respect of a doctor, the Medical Council will deal with that. We need to take a look, therefore, more closely. We need to first of all tackle the problem of private hospitals, and then we will go down step by step and determine whether regulations are warranted in the light of the risk. Dr. Ka-lau, your second round. Chairman, I would also like to ask administration one more question. Regarding your 4 working groups, I think the 4 regarding the private healthcare service providers, I think what you are saying here in this paper has nothing to do with. I think what you're saying here has anything to do with the healthcare intermediaries. Well, you may want to protect or defend the government's position, which is not forward-looking, and you are, saying things which are not true in this paper. We all know that the government will be launching the voluntary medical insurance scheme and has put in place $50 billion for the purpose. I'm sure most of the $50 billion will go to the insurance companies and these intermediaries. Have you made an assessment that is, if you give them such a lot of money, and if there's no regulation and there's no guarantee that these insurance companies and the intermediaries, there's no regulation of the service they provide, I mean, how much will the community suffer? Well, we can't measure the amount of money involved. Of course, the insurance companies and the medical healthcare intermediaries would like you to proceed with the medical insurance scheme. We're talking about public funds here, taxpayers' money. Of course, the rights of patients are also important, and we certainly attach importance to that. But now the government is going to spend $50 billion on this scheme. Basically, money will go to the insurance company and these intermediaries. So they'll be making a lot of profit. And they will take a large portion of the money, and only a small portion will go to the doctors and the patients. And the government's not doing anything about it. So what are the difficulties which, on your part, that cause you not to go for regulation? Right now, very soon we're going to set up an independent, regulator for the insurance industry. Why is it that for the healthcare intermediaries, the government is not going to do anything? Is the government trying to give us the impression that you don't want this to slow down your plan to launch the medical insurance scheme? Is that your intention? Secretary, many deputations have made suggestions as to how these healthcare intermediaries should be regulated. So what is wrong with all these proposed suggestions? Thank you, Dr. Kwok, for your comment. It's not whether or not this is good or not. Mr. Yuen also said that we have an existing regulatory regime that is regarding the professional ethics of doctors that will come under the purview of the Medical Council. Regarding the financial position of the insurance companies, again, they are regulated by the insurance commissioner. If we're going to regulate the healthcare intermediaries, so what mode of regulation should we adopt? I said earlier that we will, put them onto the agenda of this working group. What Dr. Kwok was saying, that is, they have nothing to do with these 4 working groups. The Permanent Secretary already said that the working group responsible for the regulation of private hospitals, since it will basically be focusing on private hospitals. But since we are talking about private medical services, and also given the concerns expressed by so many people, we are prepared to conduct a review and see what they should be regulated. Actually, these have nothing to do with private hospitals. I think the Medical Doctors Association have already given you a list. They have nothing to do with private hospitals. Most of these involve patients going to clinics. Yes, Mr. Yuen was saying that this working group, since it will be looking at the regulation of private hospitals, and since we're talking about private medical services, perhaps that working group can also look into this. These private healthcare intermediaries are not medical organizations. Do you understand? Well, the working group is called the intermediaries are not medical organizations. So if they're not medical organizations, and why should we regulate them? That's why members and the deputations are asking you to regulate them, because they are intermediaries. I don't know whether members will agree with you. These are not medical organizations. They are not insurance companies. You talk about the regulation of insurance companies, and you also talk about a working group looking into the regulation of private hospitals. All that is not relevant. Chairman, in paragraph 10 of the paper, we say that in our review, we will also look into the modus operandi of professional partnerships, group practice, and so on. So we will look at whether or not they come under this category. So the main purpose of regulation is to protect the patients. We need, well, some of these groups are operated by doctors, or sometimes they would engage doctors. Some of them only play the role of an intermediary representing doctors. And the situation will vary from jurisdiction to jurisdiction. So we want to be given some time to carefully consider what would be the best way to tackle the problem. Dr. Fernando Joe. We've said earlier that these healthcare intermediaries, they're not medical organizations. I think we're talking about really a financial arrangement. These HMOs, according to my understanding, although I'm not in the profession, but I've spent some time in the States, the spirit is that they will set a cap, and they also provide a minimum guarantee. Setting a cap means that for the employer who buys the service or the insurance company, they can, through this system, set a cap on the maximum expenses to be incurred. That is, for certain organization hiring so many people, they will only offer a maximum of that much amount of money to provide a medical service. For the loading, that is through these intermediaries, they will say, we will undertake a group of people. We will be undertake the medical expenses for all these people. It's basically a kind of insurance. Like I think they operate very much like the insurance companies, except that they have these intermediaries to do the liaison work. As to how quality, if you say it doesn't affect the quality of the medical service, it's not very convincing. Basically, we're talking about a financial arrangement with the objective to control cost. How can you then say that cost control will not affect the quality of service? Of course, it would depend on the standard of the healthcare medical intermediaries. Like the Doctors Association said, there is a cap on the fees payable to the doctor. So the maximum, we're talking about a maximum amount that they will pay the doctors. And for general GP clinics, that's the situation. So it's very hard to imagine that the doctor will not compromise on the quality. Our doctors are not stupid. So if for the entire profession, let's say you say they're not an insurance company, they're not regulated by the Commissioner for Insurance, and they're not medical service providers, they don't hire any doctors, they don't directly employ the doctors, so they don't come under the purview of the Medical Council. And this is where the problem lies. But these intermediaries, they will play a pivotal role in affecting the health of the people of Hong Kong, especially because the government is now launching the voluntary medical insurance scheme. So it's not possible that the government will refuse to look at this. For the 4 working groups, none of the 4 have to do with these intermediaries. Either you will create a 5th category, Yi, stipulating that you are willing to also look into these healthcare intermediaries. For 4 items are not directly related to the operation of the healthcare intermediaries. So are you willing to add item Yi? You are linking up the regulation of private hospitals with these intermediaries, and I find this really very, very, unconvincing.
Thank you, Dr. Zhang. As I said, in the working group on regulation of private hospitals, we will consider practices such as professional partnership and a medical group with management arrangement. So that's why we said that we're going to cover that in this working group. But that is only under the regulation of private hospitals. But what about private clinics? The relationship between healthcare intermediaries and private clinics. No, not just private hospitals. Of course, the working group was first set up to look at the regulation of private hospitals. But as we said in para 10 of the paper, healthcare intermediary schemes will be one type of management structure, group practice under management structure. So why don't you put it under, why don't you have a separate item, D, for this? Well, according to my understanding, HMO is a very different thing. It has got its own doctors and hospitals providing a full range of services. We don't have structures like HMO in Hong Kong. We are talking about an intermediary that organize a group of doctors together so as to negotiate with insurance companies. So we might have to rename the working group on D, regulation of private hospitals, because the relevant ordinance doesn't just cover hospitals. It includes nursing homes and maternity homes as well. So it is our original intention to cover such practices under the regulation of private hospitals. So D, with the working group on D, will cover group practice under different ownership and management structure. Because there are such things in the market, even healthcare intermediaries can come in different formats. So the steering committee is the umbrella organization. It will oversee all related matters, and we propose that the working group on D can cover healthcare intermediaries as well. Mr. Chair, an oversight. I have to give the floor to another member first. Regulation of intermediaries that can be covered by the working group on regulation of private hospitals. I'd like to know how long the government is going to take before it will give us a report. Mr. Yun, time frame, please. We have promised to complete the work in 1 year. The steering committee has started its work for a couple of months already. Perhaps the name, regulation of private hospitals, is a bit misleading. We are not just talking about private hospitals, because there's the private and public sectors, and in the private sector, the highest hierarchy is private hospitals, but we will in fact include group practice with different structures. We'll consider the relative risks and also the mode of operation, because we cannot have different standards or different modes of regulation. Because the basic principle is to ensure patients' welfare and to ensure the quality of service. So the steering committee was set up in last October. You said that the work will take about 1 year. Does that mean that the review will be completed in October this year? Well, the establishment was announced in last October. It started its work formally in February or March, around that time. So we will first work out the framework and proceed to the review. Mr. Chong Kwok-chu, I think I will allow time for the deputations to comment before the Secretary deals with my motion. So your question was for the insurance sector and also the medical sector, whether the current legislation could regulate them. Ms. Chen. Well, when we enter into agreement with intermediaries, we will consider their track record and past performance. Because they provide third-party administration, will consider their administrative support and how many panel doctors they have. So we will consider these factors in entering into agreement with intermediaries. For the company or the intermediary which ran into trouble recently, it is not really a very sizable operation. So the industry will only enter into agreement with intermediaries of considerable scale. And I agree that we have to first define healthcare intermediary first. From the insurance sector's point of view, we regard them as a middle person regarding capping the cost and underwriting the medical cost. There are two types of services. First, the insurance company try to identify an intermediary, and it will try to identify panel doctors to provide services for our clients or members. Our members need not worry because, as we've been saying, there is sufficient regulation for the insurance industry. Now, if there is any problem, we have to honor our obligation under the agreement with members. However, there might be intermediaries that have direct agreement with employers to undercover medical treatment for their employees and perhaps to cap the treatment costs. Now we are worried about this type of intermediaries. So an intermediary might have signed an agreement with an employer to provide medical services for the employees, and they might have collected a lot of membership fees. If should the intermediary close, like what happened in recent case, there is really no regulation of the agreement between the employer and the intermediary. Dr. Yang? Some healthcare intermediaries are competing with insurance companies. And the film referred to by Dr. Zhang is really happening in Hong Kong. A doctor of a healthcare intermediary might have admitted a patient into a hospital, and that patient is only allowed to consult one specialist doctor per day. So even if the patient is suffering from problems in various organs, he is only allowed to consult one specialist a day, and therefore his treatment may be delayed. As for instance, a patient might be suffering from appendicitis, and he has to get the approval of a of the doctor provided by the intermediary before he can receive an operation. Now, the doctor has not done anything wrong, although he is subject to the code, because under the agreement he must get the approval of the intermediary first. And Mr. Yun said that the working group should review the regulation of such intermediaries as well. I support this. Dr. Tse, healthcare intermediaries will control healthcare resources. So a healthcare intermediary first collect resources from patients, and they are there because there is no one to regulate them. In the service chain, the healthcare intermediary is not controlled or regulated at all, and this will compromise medical services. Let me tell you, the Code of Professional Conduct for the Medical Council of Hong Kong was drafted by me. I think there is no way the doctor can control the kind of medical services he provides to doctors. Now, if he is constrained by services available, he cannot maintain quality service. Now, even if you have a code to regulate the professional conduct of doctors, it will not be useful, because an healthcare intermediary is a business operation. Well, doctors are not in business. We are professionals. We need a medical council because if you have a practice, you have to be mindful of your professional conduct and professional ethics. So it depends on whether the healthcare intermediary is ethical and professional. So I agree with Mr. Zhang Huokchu's motion.
Mr. Lam, I'm very disappointed with the response by the Secretary. There was a medical incident last year. The government set up certain working groups to look into medical procedures and beauty services in the light of these incidents. The Audit Commission also published a report regarding the regulation of private hospitals, and because of that, the government set up certain regimes to look into this. What is before us now is that there have been healthcare intermediaries which have defaulted. As a result, both doctors and patients have suffered. So I don't understand why the government is still reservations about regulation. I believe that the question of healthcare intermediary is an ethical issue. The patients are using their lifetime saving to acquire the service. If you buy a car, if the service is not up to standard, you will not die. But if you buy medical service and if there is no proper regulation, then I mean, we're talking about a question of ethics here. Mr. Zhang Huokchu has submitted a motion, and I'll read it out. This panel urges the administration to immediately consider the enabling the regulation to regulate the healthcare intermediary organizations in order to protect the rights to medical treatment by patients. And this is seconded by Dr. Ka-lau. Mr. Wong Ting Kong. Question for Mr. Zhang Huokchu. By regulation, are you talking about regulating fees or the standard of service? Thank you. I believe whatever has happened that we need to regulate. So you're talking about an all-round regulation, including fees and service standards. Well, we're talking about a study here. If in the end the government proposed to regulate both, fine. So what about the medical council? The role of the council? I believe they know what to do. But we are playing our role. I think we need to be focused. I don't think we should aim to encompass everything. Well, actually, I want to learn from you, Mr. Zhang, but I don't want to amend your motion.
若果冇其他議
Other comments? If not, I think we can simply, have a show of hands so those who are in favor of the resolution, the motion, please put up your hand. I don't think any member is against the motion, so it's endorsed unanimously. So I'd just like to make two comments. First of all, you try to regulate service standard through regulating doctors. You believe that the doctors have a very strong bargaining power. Only then can you regulate the doctors, and through regulating the doctors can you regulate the service, so that doctors will not work with healthcare intermediaries who do not abide by ethical standards. You are assuming the doctors have a strong bargaining power. But nowadays, since there are so many doctors, there will always be many doctors who don't have such bargaining power. So you can't just rely on this or the medical council to regulate the ethics or professional conduct. You made the wrong assumption. And secondly, you've left out one thing. Sometimes it's not a question whether or not we have enough resources, but rather the intermediary. They may receive $200 from the insurance company per patient, but they only pay the doctor $100. So they play the role of a middleman. They're already, eating up 50%. So both the insurance company and the patient suffer. Even the doctor also suffers, and the person who's not regulated makes half the profit. So that's why we want to regulate these healthcare service intermediaries. We're not saying that they shouldn't be allowed to do this or that. We just want more transparency so that we know how they operate. So with that, I think we need to move on to our next agenda item. Thank you very much, all the deputations, for coming here to meet with us. The next topic is the Commissioner of the North Lantau Hospital, Phase 1.
係唔係叫梁醫生，係叫楊醫生。OK， 咁政府嘅文件同埋秘。
We have the paper from the administration. Our secretariat has also prepared background paper for us as well. So I think we can get started now. Secretary. Thank you, Chairman. Today we're talking about the North Lantau Hospital. The construction of the hospital was completed at the end of 2012. This is a community hospital which provides for the neighboring community acute and ambulatory service, including extended inpatient care services. The hospital also provides for specialist outpatient services. Given the shortage of medical staff, since September 2013, or starting from this year, the hospital will be commissioned in stages. I understand that in North Lantau, the residents' demand for medical services are very keen. They are particularly concerned about the service of A&E wards. So the A&E service will be provided from September this year when the hospital is commissioned. Initially, it would operate for 8 hours a day, and from January 2014 onward, it will be extended to 16 hours per day. Depending on the supply of manpower, by the third quarter of 2014, we plan to provide for 24 A&E service, and also we will have A&E wards. So we're doing it in stages. With the commissioning of the new hospital, the general outpatient clinic provided in the Tung Chung Health Center will be relocated to the new hospital. The existing service level of the clinic will be maintained. regarding the medicine and psychiatry special outpatient clinics, and they will also be available upon commencement of the A&E services. Other equipments like the pathological laboratories, the A&E radiology suite, and the computed tomography scanner will also be in place to support the clinical services. The HA has always been liaising with the major stakeholders regarding the commission of hospitals and update them on the latest progress. We will continue to maintain a close liaison with the residents in the area regarding the commission of this new hospital. With that, we are happy to answer member questions regarding the commissioning of Phase 1 of the North Lantau Hospital. I think we still have time, so we'll stick to the 4-minute each rule. Mr. Chan. According to the paper, since the administration is not able to recruit sufficient number of doctors, so even with the North Lantau Hospital being commissioned, you only provide for 8 hours of A&E service initially. Some people say that it's better than having no A&E service at all, while others say that this is tantamount to not having A&E service at all, because there will not be any in-hospitals hospitalization service, and for serious cases, the patient need to be referred to other hospitals. The administration points out that the Princess Margaret Hospital will also can also play a role here, and patients can be referred there if necessary. If you just consider the journey time of transferring patients to the P&M hospital, how much time would that take? And also, by referring the patients to the Princess Margaret Hospital, will they also be in conflict with the others who are waiting for the same service at Princess Margaret Hospital? While you offer, you say the A&E office will be offered for 8 hours a day, will the service be offered in the morning, the afternoon, or the late evening? Could you give an answer to those questions? Secretary. Let me answer your last question regarding the hours of operation. The 8 hours will start initially from 9 in the morning to 5 in the afternoon. Your first question was whether the 8-hour service was sufficient. We've already explained that due to the manpower shortage, we are adopting a progressive approach to launch the service. I'd like to reiterate that this is a community hospital, and in order to satisfy the aspirations of the resident, they believe that there is a need for A&E service, and that's why at the initial stage we will commission the A&E ward first, starting with an 8-hour service per day. Since it is a community hospital, generally speaking, there would be patients who need to be transferred to the Princess Margaret Hospital for treatment. So we've done some work on our part regarding the transfer of patients to the Princess Margaret Hospital. And we've also trained our staff regarding referrals. Perhaps Dr. Zhang can answer the second question. Thank you. Dr. Zhang. For Phase 1, we're going to offer an A&E service for 8 hours per day, because the A&E ward is new and we need time to try out the equipment and the facilities there. Early next year, around January, we'll extend the service hours to 16, from 8 in the morning to 12 midnight. By September next year, the A&E ward will operate around the clock. The A&E ward will cater to North Lantau residents. If they suffer from an acute disease, they can go for preliminary diagnosis there, and if the hospital can deal with the patient could be treated and go home. If further treatment, including hospitalization, were required, they could be transferred to the Princess Margaret Hospital. Journey time is about 30 minutes. Well, this is convenient for the residents. because we are able to provide expedited treatment for the patients. My question is whether or not there will be the patients will be fighting. The patients referred will be fighting for space with those in the Princess Margaret Hospital. Other people are queuing up already at the Princess Margaret Hospital, and you transfer the patients there from North Lantau. Would there be any conflict? Well, the patients will be given a diagnosis. If it is decided that they will need to be admitted to hospital, so they may not have to go to the A&E ward at Princess Margaret at all. They will be immediately, admitted, unless you have critical cases where the patient will need to go through further assessment. So, generally speaking, it will actually relieve the pressure on the A&E ward at Princess Margaret Hospital, because right now, Tung Chung residents, if they need A&E service, they will go to the Princess Margaret Hospital's A&E ward. Dr. K.K. Kwok. Thank you. I think this hospital will really is something that the residents in Tung Chung and North Lantau have been looking forward for a long time. But I think they're most concerned and most disappointed about is the A&E service of this new hospital. We understand that all hospitals are short of staff, and there's a manpower shortage across the board. But between now and according to the paper, by January, you will operate 16 hours a day, and only by middle of next year you will be able to operate the ward 24 hours a day. Would you be able to resort to recruiting staff who are not on the HA establishment to work in the A&E ward, or ask your A&E staff to work overtime? Or for the short term, can you enlist the support of private practitioners to provide the service? Many A&E doctors who have completed training have left the HA. Some of them have gone into private practice, but many of them have the ability and the time. So if the HA wishes to enlist the help for a short term, I'm sure it can be done. So can the HA and administration at this stage adopt, this approach? At least, give this a try. I think you can, starting from the end of this year, I think operating service for 8 hours a day is not acceptable. I don't think many of the A&E cases would be done from 9 to 5. And the Kaifongs would have the impression that the doctor is now billed, the equipments are there, but there's no one working there. You can just imagine how controversial this will be. And and the public will feel very, very much let down. So is there any way, or have you considered, ways to how you can, recruit additional manpower?
Secretary, thank you, Dr. Kwok, for your comments. We appreciate that the A&E department will only be operating for 8 hours a day, but then we will also extend the nighttime clinic of Tung Chung Clinic. The clinic will be moved to Tung Chung Hospital. So initially, the A&E department will only be in operation for 8 hours. But for other urgent cases, we have nighttime clinic that will not just end at 10 p.m. but 11:45 p.m. rather. So that will be done in parallel. Regarding manpower, Dr. Zhang can supplement. Thank you. Staff shortage in A&E department. Well, this is a common phenomenon. We have over a dozen A&E departments in Hong Kong. They are all short of staff. We have tried our very best to increase the supply of A&E doctors by recruitment and also employing part-time doctors. We have a special allowance for A&E doctors and non-A&E doctors to be on duty. But For operating the A&E department around the clock, the problem rests with the night time. It's quite unlikely that part-time doctors are willing to work on night shift in an A&E department, and even if they are available, they will be first be used to provide relief to other A&E departments where there is a great shortage of staff. We have to wait until the next batch of medical graduates are available. Doctor, what about giving special arrangements? So would they be considered at all? Well, we're really using special measures. If we can recruit more staff, they will be used to provide relief to other A&E departments where the demand is greater. Dr. Fernando Zhang? Yes, I'm concerned about A&E service because the residents have waited for a long time for the commissioning of Lantau North Hospital. Then they can be assured they don't have to travel all the way to PMH, which is very far away. And Tung Chung is quite uniquely located. It has got about 100,000 residents. In fact, there are a few tens of thousands of people living in Discovery Bay, and then there are tens of thousands of passengers at the international airport, and also an equivalent number of visitors to Disneyland. It's rather risky not to have around-the-clock A&E service. Now, if there is a major incident in our airport, the nearest hospital is PMH, where the journey time is quite long. Touch wood, we have not seen any major incidents yet. Well, the hardware is here. Why do we have to drag our feet until 2014-15 when we can have around-the-clock A&E services? In the interim, do you have any remedial measures? For instance, will you consider providing a 24-hour outpatient clinic service? For instance, will night clinic work? And the residents also have great demand for dental services. So will the hospital improve the provision of dental services with the commissioning of the new hospital? Thank you, Dr. Zhang. As said earlier, if the A&E department operates for 8 hours, we have a nighttime OPD an operation in parallel. It will operate until 11:45 at night. Secondly, should there be a major disaster, the HA has got a contingency plan. Through the assistance and support of cluster hospitals, there will be timely relief. Of course, Loveland Island is a member of the cluster, and PMH is also responsible. Regarding dental services, it is not within the scope of service offered by this hospital. But the OPD will close after midnight. From midnight to 9 a.m. the next day, what if residents have urgent medical needs? They still have to travel to PMH. Can you improve the situation in this regard? Yes, in the initial stage, because of a shortage of staff, indeed, after midnight, the current arrangement will continue to apply. Patients have to patronize PMH. As Dr. Zhang said, operating the A&E department for 8 hours is already a special arrangement in terms of manpower deployment. I think the HA has considered that is all it can do at this time. All of a sudden, we have a surge of questions, so please observe the time limit. Mr. Zhang Guoqu, I'm worried as to whether come January there can be 16-hour A&E services in Tongchong. However, I agree with Dr. Fernando Zhang and Dr. Kokaki. When there is a hospital there, then people expect the A&E department to be open 18 hours, no, 24 hours a day, because the hardware is already there. And according to Para 9, medicine and psychiatry specialist OPCs will be available upon commencement of A&E services. So can you give us the details? Currently, patients have to travel to Queen Mary Hospital in order to have psychiatric care. Now, I know this is a community care hospital. There is no obstetrics and other specialties, but Tongchong is a growing community. So is there the opportunity for Tongchong Hospital to be upgraded to a general hospital with more specialties available? I agree. We appreciate this issue, and that's why the hospital is to be commissioned in 2 phases. Phase 1, we will provide 160 inpatient beds. And once the operation is, the hospital is in full operation, we will consider services to be provided in phase 2. And near phase 2 of the hospital, we have got a site reserved for the construction of a private hospital. So there is room for further development on that site. Dr. Tong can tell us the needs of the residents. I believe the HA will, from time to time, consult the community there as well as community organizations there. Dr. Zhang, Mr. Zhang is worried that we won't be able to operate the A&E department for 16 hours a day. In fact, we have already reserved manpower for that. To start off, we offer an 8-hour service because this is a brand new hospital and it takes time for us to get used to the operation of the hospital. So give us some time and the A&E services will be extended to 16 hours a day. And then in September, when the A&E services start, we will have other specialties and will also enhance our outreaching services. And supporting services such as X-ray and laboratories, but they will also be available. We have a preparatory group for commissioning the North Lantau Hospital. In the past couple of years, we have been very actively communicating with community leaders and local residents. We fully appreciate that the community has expectations for us, and community leaders have given us a lot of input so that we understand their service priorities. So, but in the provision of manpower, we've encountered certain difficulties. In our informal discussion with the residents, and when we invite district councillors to visit our hospital, when we brief the district council, will continue to liaise with residents. And if there are forums, we are more than happy to continue this dialogue with the residents so that they know our plan and the time frame for availability of services. I understand that the community really wants to have around the clock A&E services. When come July next year, when we have new doctors, we will redeploy our staff, hoping that in the third quarter of 2014, we can extend our A&E services to around the clock. Mr. McMahon. Chairman, there will be 8 mental health clinics. I'd like to know whether there will be new services for primary health care compared with the clinic in Futong Estate. Will more cases be entertained every day as a result? As regards specialties, some patients are triaged to PMH. In the future, how much will the waiting time be shortened? And phase 2, we know that the site next to it is for private hospital, but we've asked whether there are still people interested in building private hospitals. The population will grow for sure, but it's mainly a place for PRH. So the site might as well be given to phase 2 of North Lantau Island so that there can be room for providing more beds and services. All right, and that's almost it. Secretary, thank you, Madam Mag. I will take your third question first. In phase 2, there is already site reserved. The first phase is North Lantau Island, and there is land reserved for expansion. Further, next to it, there is a site previously reserved for construction of a private hospital. Yes, I understand that there might be a housing estate built there. We will try our best to secure that site for further expansion of services. Regarding triaging, perhaps my colleague can supplement. And services or primary healthcare services or general outpatient clinics. First, the clinic will be moved to the hospital in the first instance. There will be no cut in the number of quota or number of slots per day. The service level will be maintained at the same level because it mainly provides treatment to the elderly and the chronically ill. The facility will be improved because the new facility is bigger and better, so there is enhancement in the hardware, but the number of slots per day is just the same. When it comes to GOPC, the number of slots per day will not change, but as the Secretary said, there will be improvement in hardware, and that will give us the potential to increase the number of slots per day when necessary.
We're talking about patients at the quota for the general outpatient clinics, for the allied health clinics and so on. Initially, we were able to have some increase already. Regarding the specialist outpatient clinics, once that is started, we can see, first of all, that if we see there is when we see a new referral, for the simpler ones that we can deal with, they can be dealt with at the North Lantau Hospital, so they don't have to be transferred to PMH. We do not have the actual experience yet, and therefore we're not able to give. We don't know what the statistics will be like. Mr. Tenkapio, several questions. I'd like to declare my interest that I'm a member of the Island District Council, and the HA had consulted the Island District Council, and there was not much objection to this project because we can't object to having a hospital in the district. But how can we ensure that by July next year you can ensure that there will be sufficient doctors to enable you to offer around-the-clock A&E service? Could you give us a more specific answer? And secondly, I'm also concerned about the specialist outpatient clinics. Not to mention the complicated specialist cases like tumor and cardiovascular diseases, or even for urology and ophthalmology. I understand that you have not yet planned for these specialist services, and the patients need to go to the ophthalmology hospital or Caritas, and they have to go all the way to Samshui for treatment of the eye disease. Many of them simply give up the treatment. So can you come up with ways to make up for this shortfall? Would you consider resorting to a non-emergency sort of service? Thirdly, now that the hospital is now built, right now we relied on bus number 38, and many doctors and medical staff may choose to walk to the hospital, and people are asking that you would build a shelter. Could you build a shelter for the Tung Chung community? 3 questions. Let me answer your second. I'll ask Dr. Yun to answer the first and third question. I'll take the second one. You talk about specialist treatment. Dr. Chung already told you that when they liaise with the local residents, we realized that there is a demand for some specialist services. So in September this year, there will be 10, consultation rooms for medicine and psychiatry for the specialist clinics. We'll adopt a progressive approach so that by 2014, 2015, there will be specialist treatments for pediatrics, gynecology, and orthopedics. As we continue to launch our services, the HA will monitor the needs of the residents, and we will constantly be in touch with the district council to find out about the service that we have launched and how they are doing. As to how we can ensure that we will really have sufficient manpower in July next year. Well, in our plan, we've already made provision that when we have the next batch of new medical graduates, there will be additional doctors deployed to the A&E wards. The new graduates, of course, will not all be deployed to North Lantau Hospital, but we may deploy some staff from other A&E wards, and then we'll make up for those who have been deployed to the North Lantau Hospital with these new graduates. But there are 2 other ways by which we can ensure the supply of new doctors. The A&E ward at North Lantau will not operate as a single department. It will work as a team with the A&E ward and PMH. So both the senior doctors, and so we can ensure that there is a proper rotation. And secondly, we want to attract doctors to go to the new hospital. Training is very important. In the long term, we have planned for the A&E ward at North Lantau Hospital to become a training center that can ensure that doctors who are willing to go and work there. On the subject of the shelter, Mr. Lee could perhaps take that question. The local residents would like, at the Tung Chung MTR station, they want a shelter, on top of the passageway, but only part of the passageway is within the boundary of the hospital. So if the government is going to build that, we will also work in tandem with the administration. In September, we had a case study where we discussed with the Transport Department and the Highways Department about this subject. And they need to conduct a further study to decide whether or not they will build that shelter. Once they made the decision, we will certainly work in tandem with them. Mr. Abato, I think the residents are not only concerned about the hours when services are available. There is a limited number of hours, 8 hours per day. While this is better than having none at all, but they're still very disappointed, and they would like you to provide the normal service hours. Another concern is the quality of service. How does this new hospital compare with a fully operational hospital? Basically, we're talking about you're offering A&E service, psychiatry, and medicine. So I don't know service. You have more than 100 beds, where after a patient has been admitted into A&E ward and they have to be hospitalized, then they will stay at the Tung Chung Hospital. But you don't have any specialist clinics at all. When people are taken to A&E ward, normally they will suffer from trauma or have broken bones or something wrong with the heart, or they're suffering from high blood pressure and so on. If you don't have any specialists at the Tung Chung Hospital, what sort of service can you offer to the patients? And secondly, what is the establishment for the entire hospital? If you only offer such restricted service, people really have concerns as to whether or not it is safe to be admitted to that hospital. Could actually, allay such concerns on the part of the public? Secretary, thank you, Mr. O, for your question. Let me first of all provide you with some information regarding our establishment. When the hospital is fully commissioned, we need to hire 650 staff, more than 60 doctors and 170 nurses. When we start the service, the number of doctors, we need 28 doctors, 78 nurses, and 48 allied medical staff and 100 odd supporting staff, totaling 355. Well, the position of this hospital is that it is a community hospital. We hope that this hospital can cater to the needs of the residents at North Lantau. Well, the area is rather remote and inaccessible. Providing a community hospital here is very important. But the positioning of this community hospital means that when there are really urgent cases where there are services which are only available at PMH, we will arrange for the patients to be transferred to the PMH, because the PMH, only the PMH is an acute hospital. Regarding the arrangement for the transfer of patients and so on, they are already in place. And Dr. Tung can perhaps elaborate further on that. You also alluded to the quality of medical service. Dr. Tung could also supplement. Thank you. First of all, we must reiterate that the North Lantau Hospital is a community hospital during phase 1, or even when it becomes fully operational in future. It's not a general hospital per se. Regarding the A&E ward, we will consider the demand. For example, if you have a patient may require the service of a hospital which have cardiac experts, and they will be immediately transferred to PMH. If that is not necessary, we have our A&E doctors and the related specialists who will provide for treatment for the patients. I think Mr. O can rest assured that when we offer service, we care a lot about the standard of service, and we would ensure that the services will satisfy the safety standard. And if the patient really needs to be transferred from North Lantau Hospital to another hospital, our medical staff will, in the light of the needs of the patient, and if there is such a need, our nurses and even our doctor will accompany the patient when he or she is being transferred. Given the unique characteristics of the North Lantau Hospital, we will enhance the training for our doctors and nurses working there. We also enhance our facilities and equipment. You say when there's a need, there will be specialists who will offer, consultation and treatment. Well, where would these specialists come from? You don't have any resident specialists at the hospital. Of course, our service will steadily be provided. Right now, we offer medicine and psychiatry wards, and from 2014-15, we will gradually step up the other specialist services. We do not have specialists resident in the hospital 24 hours a day, but we do have, A&E doctors. The specialists would provide, would service in the area of surgery, operation, and so on. But there will be joint consultation to take care of the service of the patients. Will you need to summon doctors from other hospitals to take part in the treatment or diagnosis? Now, in future, when it comes to that stage, our hospital will increase our manpower. If we're talking about a few people, if they form a team among themselves, it may not be a very mature team. So we will team them up with PMH so that they will get the support from PMH. It wouldn't be the case that when the doctor is on leave or when he needs to undergo training, we're short on manpower. So for this particular need, the Northland Hospital will have such an establishment. I propose that we extend our meeting by 15 minutes. Thank you. I think members are very concerned about the shortage of doctors. In September this year, the hospital will be commissioned. So how many doctors will be available working at the hospital in September this year? Regarding the manpower shortage, Dr. Leung always say that there are a lot of resources in the private sector. The question is that the pay that you offer may not be attractive enough. Well, I think this is the most effective solution to the problem. Even you say that there will be new graduates coming on stream. Of course, they have been subject to stringent training, but their experience and standard may not be as good as the more experienced doctors. You need experienced doctors to lead them. So if you could leverage on the resources provided by doctors in the private sector, you end up with a win-win situation. So could you tell us, what are the difficulties for you to recruit, private practitioners to work for the public hospitals?
I defer to Dr. Zhou. Speaker is off mic. Yes, first about manpower. We expect to provide 8-hour A&E service in September and 16 hours next January. So 15 doctors have been deployed to the NT-West cluster. So manpower is not a problem. As regards how we can attract more doctors, first by recruitment, and this is subject to the constraints of new graduates. And we've also recruited about 280 doctors from the private sector, but it's a bit difficult for them to be on night shift because they have a practice in the private sector, so it's hard for them to be available at night. And for limited registration, through limited registration, we have increased the supply of doctors, although to only a limited extent. The important thing is to retain talent. After we have implemented new measures, we have improved wastage, we have retained more doctors. So we have short and medium measures, midterm measures to improve the situation. I'd like to follow up. You must discuss very proactively with Dr. Leung, because he's been saying, he's sitting next to me, he keeps saying that there are ways to tackle this problem. And we have fewer pregnant women of Hong Kong residents coming to give birth in Hong Kong, and this may help to retain obstetricians. So I'd like to know whether this is a way out. Well, obstetricians can only become gynecologists, but not other specialties. A&E, no, they cannot. Their qualifications not recognized. Well, under our special allowance scheme, they can serve in other specialties, but not A&E departments. Madam McMakin, thank you. Regarding outreaching nursing services, what will be the services to be provided? Because in Tung Chung there are dilapidated villages, and we have seen patients that are not very mobile. How are you going to extend your outreaching services for this group of patients? And as Mr. Tan Kah Piu said, it's not easy for residents to go to the Airport Express station, so please build covered walkways for them. It's also important for patients or also visitors. We all, the visiting hours are around 6 p.m. Until 9 p.m. So everyone will be looking for shuttle number 38 bus at Tung Chung Station, MTR station. But that is the peak time after office hour. So can the hospital provide more transport links between the hospital and other public transport stations? For instance, would there be more buses and shuttle services? Professor Chen. Thank you. Regarding community services, community care, we have outreach services, and all these services will start from September 2013, when the A&E department is up and running. With psychiatric assessment team, there will be also a psychiatric outreaching team, community nursing service, patient resource center, education center, and also medical social welfare department services. Public transport, well, this is not just to satisfy the demand from hospital services. The whole community needs more public transport services. Our hardware design has taken this into account. At our podium, we have reserved space for GMB and bus stands, and we've already relayed our intention to the transport department, and we're already well prepared for more public transport services. The geographical location of the hospital is that the main entrance is on the first floor, not at grade. So if we just rely on number 38 visitors or family members, will have to take escalators or lifts or use the stairs, so it's not very convenient. We have provided space at our podium for public transport services. Well, there is still some time left. I promised to give you some tips. Now, Professor Chen, you keep saying that you don't have enough doctors and A&E departments. You're employing part-time doctors and also doctors from other specialties. You only pay them at the rate of 70% of the average hourly rate, claiming that they don't have to work night shifts. Now, for full-time A&E doctors, they have to be on night shifts and day shifts as well, assuming that they are only worth 70% of the hourly wage, that means at night time a doctor is worth 2 to 2.3 times of the wage, so you should give them 3 times or double pay. I've discussed with in charges of A&E departments. They agree that you must give them differential pay to attract doctors to take on night shifts, inconvenient hours, unfriendly hours, should offer higher pay. So for daytime, you only offer 70% of the hourly wage. At night, when you employ part-time doctors or other specialist doctors to be on night shift, then you should give them double or triple pay, to be fair. This is also the suggestion of colleagues working in A&E departments. Now, there is no need for you to respond because I already explained to you the rationale. Secondly, should there be an industrial accident at Disneyland, will the victims be transported or transferred to PMH or North End Hospital? Thank you, Dr. Leung, for your suggestion. You get my suggestion. Yes. An industrial accident at Disneyland is traumatology. Well, we have a trauma center. Although the A&E department at North End Island will be up and running, it is not a place for, it's not a trauma center. So the victims will be sent to PMH. But if it's just ordinary fractures or injuries at North End Island, and for serious cases that require surgeries, PMH, serious trauma cases to PMH. We have a checklist of where to send patients. Well, if we're not talking about serious trauma cases, all cases will be sent to A&E Department of North Lantau first for assessment and first aid first. Because the department at the hospital might be able to deal with these cases and patients can be discharged. But there may be cases where the A&E department there cannot handle. Well, if a surgery is needed, then it's transferred to PMH. Please, burst of vein, a major aorta artery. For instance, if a 60-year-old man fell, and if upon arrival at Tung Chung Hospital it's found that his aorta has burst, then that would be too late. Well, we have this primary diversion arrangement. Instead of the nearest A&E department, patient will be sent to a general hospital for trauma cases. For non-trauma cases, should first aid and stabilization be done first before sending to a general hospital where there is no agreed treatment, even internationally. All right, you will first, the A&E department will be open from 9 a.m. to 5 p.m. You know, that is not the peak time of an A&E department. Why don't you juggle the time a little bit so that the A&E department will still be in operation after dinner? Because daytime, many residents are not in Tung Chung. They might be in the urban areas. All right, 8 hours. It's just for a short while. Well, when the hospital is new, if there is any maintenance or repair needed, you can only have help during daytime. Dr. Kwok Ka-kit. The special, you have special arrangements for general OPC. Will equipment such as the defibrillators be available to provide first aid or resuscitation? This is important. After 5 p.m., there won't be any A&E service, but there should be the necessary equipment for resuscitation and also trained personnel. And the administration claims that this is a community hospital. Now, this is very critical. We were first told that it would be a general hospital, or rather it's an expectation that a general hospital will be built there. I think Dr. Zhang knows the whole story. You may say that given the population size, perhaps it doesn't warrant a general hospital yet. But what about specialties and hospitalization? Both hospitalization and outpatient services are needed acutely by the community. When will these services be available? For instance, the elderly require geriatric services. Yes, I know you have the medical department, but what about orthopedic, OPD, and oncology, OPD, and ONG, OPC, and also pediatrics, OPC? These are needed by the public. We understand that hospital services of these specialties may not be available yet, but they do need outpatient specialist outpatient services in these areas. When phase 1 is in full operation, we will have all the services you referred to, ONG, medical, surgical, pediatrics, mental health, orthopedics, so on and so forth. But what about oncology and geriatrics? There is a big elderly population there. Do you have geriatrics, OPC? And also after 5 p.m. when the A&E is closed, do you have the necessary resuscitation equipment there, including defibrillators there? For instance, a patient has suffered from shock. Do you have the basic requirement to revive him? Dr. Kwok, you can rest assured. These are really very basic facilities for first aid and resuscitation, and there will be training to staff to cater for such needs. Regarding geriatric services, yes, we will cover that.
Under the medical service, together with our outreach service, our outreach team in future will step up its geriatric assessment service. Regarding oncology, for the time being, we don't have that yet, but we will not rule out that sometime in the future when there is a need, and if resources allow, then we will provide for the service. We will not rule out that option. So in a nutshell, we all know that PMH geriatric service has a very long history and they have sufficient staff. My question is that once you confirm that under medical service you're going to have also a substream for geriatric service. Okay, since there are no further questions.